Idiopathic pulmonary fibrosis, a clinical challenge of relentless progression. Idiopathic pulmonary fibrosis (IPF) stands as the most aggressive and fatal subtype of interstitial lung disease, characterized by irreversible scarring of the lung parenchyma, progressive respiratory decline, and high mortality. Despite being a relatively rare disease, IPF affects approximately 32,500 new individuals annually in the United States, with global estimates suggesting rising incidence due to improved detection and aging population. IPF poses a unique clinical challenge owing to its rapid progression and poor prognosis. Without treatment, the median survival is 2.8 years and marginally extending to 4.2 years with the introduction of antifibrotic drugs such as nintedanib and Perfinex or Perfimidone, as demonstrated in pivotal impulses and ascent trial. Remarkably, the 5 years mortality rate for IPF at 83.2%, which exceeds the several common malignancies including colorectal cancer, which is 65.9%, and breast cancer 9.2%. The disease trajectory is marked by significant decline in pulmonary function. Patients typically experience a 40% reduction in diffusing capacity of the lungs for carbon monoxide (DLCO) within 18 months of diagnosis. Forced vital capacity (FVC) dropped by approximately 173 ml annually even in clinically stable patients. Quality of life also deteriorates rapidly with St. George's Respiratory Questionnaire, that is SGRQ score, worsening by 5 to 8 points per year, particularly in the activity domain. With 3 years of diagnosis, over two-thirds of patients report difficulty with daily living activities and 78% require long-term supplemental oxygen. Pulmonary hypertension (PH) complicates the course in 30 to 46% of interstitial pulmonary fibrosis patients and significantly raises mortality risk. When mean pulmonary arterial pressure exceeds 25 mmHg, mortality increases 3 to 6 fold. Acute exacerbation occurs in 5 to 10% of patients annually, are devastating and reduce survival by 50% within 4 months. Lung transplantation remains the only intervention capable of substantially prolonging survival, achieving a 5-year survival rate of 67.3% in high volume centers. Yet, only 2 to 3% of eligible patients undergo transplantation, mainly due to organ scarcity. Etiologically, IPF is a multifactorial genetic predisposition such as MUC5B promoter variant present in 35.7% of cases, telomerase mutation PERT, PERC, PARN, and familial history are significant contributors. Environmental exposure, especially in a cigarette smoke, that is 64.5%, metal or wood dust 23.6%, and microaspiration due to gastroesophageal reflux disease GERD seen in 87.5% of patients. Further compound disease risks and accelerate fibrosis. Molecular mechanism patient points to impaired alveolar epithelial repair, telomere shortening, TGF-beta mediated fibroblast activation, and latent viral infection, that is EBV, CNV, HHV8 as a key driver of pathogenesis. Clinically, the GAP, Gender Age Physiology Index, has become a valuable tool in predicting mortality. GAP stage 3 patients exhibit a 3 years mortality of 76.8%, while stage 1 patients have a comparatively low risk of 16.3%. Comorbidities, especially pulmonary hypertension, coronary artery disease, and GERD, significant worsen outcome, reducing median survival to 1.9 years despite treatment. So, in conclusion, interstitial pulmonary fibrosis is a relentless and complex disease with a dismal of nature course. Early diagnosis, timely initiation of antifibrotic comorbidity management, and consideration for a lung transplantation are essential to improve patients' outcome. Greater awareness, multidisciplinary care, and ongoing research into pathogenesis and targeted therapies remain crucial in confronting this modern respiratory epidemic. Thank you.